But these people aren't dying from COVID. Let me give you several examples here. An anesthesiologist intubated the patient's, like, I think it was right, bronchi and of a patient, and they couldn't get the sats up, and for about 5 hours, like, we were waiting on a chest x-ray to confirm that the placement was wrong. And in the meantime, while we're waiting for that, and we've told the anesthesiologist that it was placed wrong, because, like, literally only one side of his fucking chest is, like, inflating, he dies. Okay? A patient had a heart rate of 40, and the resident started doing chest compressions on him, which is not what you do. You just externally pace them, or you give him some atropine. And then, I run in there to stop him from doing chest compressions on somebody with a fucking pulse. And then he decides to push epi. He throws some pads on him to defibrillate the guy in bradycardia. Okay, he has a heart rate of 40 in a stable, bradycardic rhythm. We just need to give him some atropine and pace him. He fucking defibrillates him and kills him. And I was literally ran out of, like, the patient's room to get, like, the director of nursing who was standing out there. And I'm like, can you stop him? He's going to kill that patient. He's going to kill that patient if he defibrillates him with bradycardia and a heart rate of 40. And the director of nursing just shook his head. And I turned around and he killed the dude. Okay? There was a nurse who placed an NG tube into some guy's lungs and filled his lungs with tube feeding. There was a nurse who confused a long-acting insulin with a short-acting insulin and gave 30 units of a fast-acting insulin and killed the guy. What else? Other stuff have I seen? Yeah. It's just here they're just gonna let them rot on the vent. They're medically mismanaging these patients. And, like, I'm not a doctor, guys. I'm not professing to be a doctor by any means. But there's, like I said, basic standards of care that we have to do. Like, when somebody's low on blood, like literally on the brink of a critical low blood level, we should replace the blood. But I asked the residents, and they're like, does he have internal bleeding? And I said, no. Then they're like, well, then we're not replacing the blood. Well, here's the thing. In these COVID patients, they all eventually need a blood transfusion. Their blood, like, if you don't have enough blood to actually oxygenate your body, the vent settings don't fucking matter, okay? They don't matter because you have no oxygen carrying capacity of your blood, okay? I told you about the patient where, like, all that, like, purulent drainage just kept seeping into his lungs because the ET tube cuff was leaking, and nobody has a fucking manometer here to check the pressures. And I finally figured that out. And I kept saying, hey, you know what? His white blood cell count is steadily, like, we're having a problem with it. Like, do you want to start some antibiotics? No. Well, does he have a fever? And I said, no, he doesn't have a fever. They didn't want to start antibiotics. Day shift nurse finally got a chest x-ray. He has full-blown pneumonia now. Like, I've been telling them this for a while, but because he didn't have a fever, they didn't want to give him antibiotics. We have a nurse who, like, fell asleep at the fucking nurse's station while we were all in rooms, and her norepinephrine ran out, and the guy had no fucking blood pressure and didn't perfuse his brain, and I'm pretty sure he's brain dead. That same nurse is now running a CRRT machine, a dialysis-like machine, that she has never done before. She said she'll figure it out, okay? I'm pretty fucking smart, and I figure a lot of shit out, but I would never attempt to try and figure out a CRRT machine on the